Bakit ayaw ma-share ng slideshow? Anyway, good morning everybody. Hi. Hello everyone. Is anybody there? Ayan, good morning. So how is everybody? Last week I was giving you guys a lot of difficulties, but now naka-select na ako ng 5 students na possible manalo actually. Mamaya ko i-announce kung sino yung nanalo, pero I will give you guys the names of the people who are in the running of winning the 500 peso load based dun sa ano natin, pre-test on hematology. So, I selected John Ilagan, who was the last person. Okay, John Ilagan. And then the earliest person who submitted the assignment was John Ilagan, and then the other one is also another John, which is John Miranda, Alphys Odfina, Earl Palmero, and Rachel Tucero. So sila yung maglalaban-laban para dun sa highest score. O di ba guys? May mga challenges tayong mga pinagdadaanan. So hopefully dun sa lima na yon may mananalo. Doon ako mamimili kasi i-check ko yung grades nila. And then at the end of this lecture, I will announce who's the winner. All right? All right. So can we begin na? Is everybody ready? Is everybody awake? Are you guys ready to discuss hematology? Talk about your blood, talk about anemias. So our topic for this particular lecture is about anemia. Okay, so by definition, anemia is the basically just lack of oxygen carrying capacity. So anything that causes the lack of oxygen carrying capacity of the blood, that is defined as anemia. Okay, so that's the question in our first slide. What is anemia? Okay, can you see the slides? Can you guys see the slides? Okay, so a disease associated with low level of oxygen carrying capacity, either through disease, either through a decreased number of RBC count, okay, RBC production rate, or dysfunctional RBC in general. Okay, dysfunctional RBC. So please don't forget those three criteria in which oxygen level carrying capacity is lowered. So decreased number, decreased RBC count, and then RBC production rate and dysfunctional RBC. So the last one is a little bit vague. So I'm going to give you guys a little bit of an idea what you mean by dysfunction. So it could be either through a damage in any of the components of the RBC. It could be the hemoglobin, it could be the globin chain, it could be the structures of the glycoproteins in the cell wall of the RBC. So those are the basics of anemia. So we're going to move on with this one. What is the RBC index that is often used to classify anemia based on size? So based on size, we can answer from our previous lecture. I will go back to our previous lecture and ask somebody from anybody random. What about Gina? Hi, Gina. You're the first one in the. Hi, Gina. Can you open your camera and your microphone for me? Because I'm going to ask you a question from the previous lecture. Hello? Hello, Gina. Gina is not here. All right. What about John Ilagan, who is a person in the running for um, John? Hello, John. Ay, ikaw pala. Ay, oo nga pa. Hi, John. Ikaw pala si ano. Hi, John. I want you to answer this question for me. What RBC index is often used to classify anemia based on size? So we talked about RBC indices last week, right? So you have MCV, MCH, and MCHC. Which one of those three do you think would be the one that would be able to, that we can use to answer this question? Based on size. based on size. You have three choices. I Very wrong, John, but thank you for participating. I will ask you again later. All right. Thank you. Bye. It's okay. What about another student before we move on? Who else? What about Mikey Polino? Hello, Mikey. Oh, somebody answered already on the chat. Maria Bulawin answered MCV po. I will not consider your answer correct because you added a question mark. So you are correct by oh my gosh. Nagalit siya. Sumagot siya MCV. Oh, yung isa naman, all caps naman yung isa. Apple Lagrana. Alright, Apple Lagrana is the one who answered correctly because her spelling is spot on. You have to put capital letters on it. But in the exam, don't worry, it's all multiple choice. You will be able to answer it if you remember the question. Alright? So we're gonna move on. The RBC index that we're gonna be talking about is bakit hindi gumagalaw yung slide ko? Wait, guys, hindi gumagalaw yung slide ko. Nasaan na ba siya? Ayan, gumagalaw na. Alright. So the correct answer is mean corpuscular volume. Alright, mean corpuscular volume is going to determine the size of your RBC. And the normal value for the mean corpuscular volume is, what's the answer? Anybody can answer from our last discussion, the last week's discussion. Can anybody answer? What about, munti ko na matanong si Miss Christina, siya pala yung, siya pala yung teacher niyo. Anybody on the chat? What is the normal value for mean corpuscular volume? Apple, Enna, Maria Bulawin. 87 femtoliters. 80 to 100 femtoliters. Very good. So somebody answered it correctly. That's Ina or Enna. All right, femtoliters. You have to, yes, correct. You have to use the correct units, guys. Please don't forget the correct units. Okay. So let's move on to the next one. The next one. Medyo slow. Nag-warm up pa tayo, guys. What are the classifications of anemia based on size? So from the name itself, if you have the normal value of that one, which is 80 to 100, 80 to 100 femtoliters, you will consider a cell known as normocytic. A cell is macrocytic if it's greater than 100, and a cell is microcytic if it's less than 80 femtoliters. So please don't forget this one because you might be asked a question in your exams. Especially in my exam, I will post anemia questions there. So please focus on the anemia questions. All right. Please be mindful of the topics of anemia because these are things that are normally asked in the board exam, especially the computations for these ones. So I hope you guys read the previous previous slides from before. All right. Okay, so what are the examples of microcytic anemia? So we have three examples now of microcytic anemia that we will discuss here. We have iron deficiency, okay? We have anemia of chronic disease and sideroblastic anemia. So the problem for each will be in this slide as well. Low dietary intake or blood loss, okay, for iron deficiency anemia. For sideroblastic anemia, you have a problem with the heme, okay? The heme production is dysfunctional. All right. For thalassemia, sorry. So for thalassemia, it's a genetic disorder. Okay. For coding, that's coding, guys. I will change that. I will change the. Sorry. So I will change that one. That there's a typographical error. All right. So there's a problem in thalassemia. There is a problem in the coding for alpha and beta globin chains. All right. So the difference between these three is very important for you guys to understand the difference, the abnormality with the types of anemia. Okay, so iron deficiency, there's low dietary intake. You're not taking in iron from the diet. Usually, you are in a vegan diet. Okay, blood loss is also an important one. So you got shot, or for example, you were involved in an accident that can cause iron deficiency anemia. Sideroblastic anemia, on the other hand, there's a problem with the heme production. So it's either in the pathway of porphyrin, okay, or you suddenly took in there's a congenital problem in the productions of your porphyrin, or there's a problem with your heme production in relation to taking in toxins. Now, in thalassemia, we will discuss this further later on when we reach this one. But I want you guys to remember that there is a problem with the gene coding for the globin chains. By the way, guys, what is the structure of your hemoglobin ba kasi? All right, so I'll draw it here, and you guys can look at it. Um, well, this one is red. All right, so your hemoglobin is like this. It's basically like a protein with four globin chains. Okay, those are four globin chains. Let me change the color of. How do I change the color? I'll use a highlighter for the other ones. Okay, so the ones at the bottom and the ones at the upper right side. Okay, so you have two alpha and two beta chains. That is your normal hemoglobin structure. Okay, inside is your iron group. The iron is in the ferrous group. Okay, so that's the basic appearance of your hemoglobin. Where is it located? In your RBC. So I'm going to draw your RBC here on this side. All right, so I'm going to draw the RBC on this side. So the RBC is biconcave in shape. Medyo pangit, guys, pero please bear with me. That's biconcave. When you look at it in the blood smear, you will be looking at it on the top view, which is usually this one. There is a central pallor indicating that the cell is biconcave. Okay, there's a central pallor. All right, so that's the structure of your hemoglobin and your and the shape of your normal RBCs. So the normal lifespan of an RBC, guys, anybody can answer on the chat. Can anybody answer on the chat? The normal lifespan of an RBC is. Oh, can anybody answer? Wait, hindi ko nakita yung ano. Wait, where's the where's that one? All right. Hindi ko nakita ko may sumagot. 120 days. Cyrene Alvarez. Hi, Cyrene. This is the first time I'm seeing your name. So I would like to say hi to you. All right. Okay. So another one answered. Earl. April. Thank you. 110 days. Yes, very. That one is actually the most complete answer you're going to get is 110 to 120 days. So in some books, if you're not using Rodak, you're not gonna see 120 days. If you're using Henry's, you're going to see a range, 100 to 110 days. Those kinds of numbers will arise. Depends on the examiner who's gonna make your exams. Okay. So please be mindful that there are different books, but usually the most common one is 120 days. And this is considered as a high yield question because most of the time examiners are going to test if you remember the basics of hematology. And please remember this one. All right? Now we're gonna move on with the different types of anemia. I've discussed to you guys what is the difference, what is the what do you call this? What are the different types of anemia based that are microcytic? So these are microcytic anemias. I forgot to mention, I added earlier anemia of chronic disease, but that's actually between microcytic and macrocytic. So please bear in mind those one. Normocytic and macrocytic rather. All right. Now, trivia. What is the most common cause of anemia? Can anybody answer? What is the most common cause of anemia? Anybody? There's a trivia. It's not nice to know. It's somewhat an uncommon question that is asked. Anybody on the chat can answer. Don't worry. What is the most common cause of anemia? And your choices are these: iron deficiency anemia. Very good. Somebody answered correctly. Iron deficiency anemia. So guys, please, if you want to learn something today, I want you guys to be um to to be on the same manner. Don't try to cheat. I know I sent the I sent the PowerPoints for you guys, but I want you guys to challenge yourself in answering the questions that I'm posting, all right? Because these are going to be your flashcards. It's going to be for you guys. You can do whatever with it. You can add it. You can delete it afterwards. But this is going to be an important part of your discussion today because most of the discussion will revolve around this PowerPoint presentation that I prepared for you guys because I love you guys that much. Anyway, let's move on. Correct. Correct. The most common form of anemia. Sorry. The most common form. Can you guys see what I'm looking at now? It's not. Why isn't. All right. All right. It's not presenting. I'm not sure why. All right. I don't know why it's not moving. Is it moving now? Can somebody answer me via voice? Is it moving now? Okay. So we answered that one already. The most common form of anemia encountered in the clinical laboratory is iron deficiency anemia, whatever the cause is, or whatever the cause of the iron deficiency, it doesn't matter because it is the another high yield question that might be asked from you. It could be phrased such as this: which of the following anemias would you encounter in the clinical laboratory most of the time? Or it could be asked the most common form of anemia encountered in the hospital setting. So those are the types of questions in which the examiners are trying to see whether or not you understood the material. All right. So we're going to move on with iron deficiency anemia. And the next question is clinical laboratory findings of patients with IDA. I've divided it into two types. You're going to look at it in the point of view of a clinical chemistry medical technologist and in the person and in the hematology department. So for clinical chemistry, you're going to look for two things: liver enzyme. Sorry, uh, you're going to look for transferrin and ferritin. All right? That's the most important thing that you need to look for. When you're looking for in the blood film, obviously you will see microcytic hypochromic anemia. Why? Because microcytic because as I mentioned before, the size of the cell is less. Wait, highlighter tayo. Ay, mag-pen tayo. The size of the cell. Okay ba guys? Gumagalaw ba yung slideshow dyan sa monitor nyo or hindi? Ay, hindi gumagalaw. I'm so sorry. I'm so sorry, guys. Talaga, ayusin ko na siya. I want to discard. Ayan. Eto, okay na. I-move ko ha. So, the storage for... Balik tayo. Okay na yan. Ang question natin is, what laboratory finding? Please interrupt me if the slideshow is not moving, guys, ha? Because sometimes, nyaw-nyaw lang ako ng nyaw-nyaw, guys, and I'm not sharing. I'm not saying, and you're not learning, and you're not seeing the visual aids. So please remind me. It's okay. You can put it on the chat. You can say, sir, hi. Salita ka ng salita. Diyan hindi ko naintindihan. Hindi ko nakikita ang visual aids mo. So you can interrupt me. Don't worry. I'm pretty chill. All right? So chemistry tayo. You're going to look for ferritin and transferrin. What do you think would be the ferritin of the patient with IDA? So a patient with IDA is like this. I'll be drawing something. You can see what I'm drawing. I'm gonna write a check on this part, chemistry. Can you guys see the check that I put on the I highlighter pala? Can you guys see? You can see? Oh, oh, I'm sad. Oh, all right. Mm, try to stop presentation again, and then I'm going to share again. All right, I'm gonna share it again. Share only. Share entire screen na lang kaya. Screen 2, ayan. Okay na. Carry na guys. Ayan. All right. So as you can see, iron. What are the laboratory findings in patients with May nag-chat. No po. Ah, okay. So what are the laboratory findings that we can see? You're going to have ferritin, ferritin, and transferrin. O, di ba sinulatan ko? Ang pangit ng sulat ko. Pero maintindihan. Basta transferrin yan, guys. Yung T and F. Okay? Alright. So, what are we going to look for? Ferritin would be lower. Okay? Ferritin would be lower. And transferrin would be high. Why is transferrin high? Because transferrin is measured in the laboratory as TIBC. Okay? It's TIBC, guys. Please don't forget. Transferrin in the laboratory is measured as TIBC. Does anybody know what TIBC is? Anybody? Does anybody know what TIBC is? Who said that? Who said that? I can't, I know. Who said that? Total iron binding capacity. Somebody said it, but I don't know who you are. So I'm guessing some stranger answered for me. I didn't hear you. I didn't see you. So I'm gonna assume somebody answered correctly. So Apple is correct. Total iron binding capacity is your transferrin. So ready ang mga transferrin nating mag-bind. All right? I or Fe is the storage form. Ferritin is actually the storage form of your iron. So it just goes to show that the more readily the body is for binding to iron, the more the transferrin level would be higher. So it please be mindful of that one. The lower the levels of your iron is, that is also directly proportional to the ferritin levels. For transferrin, it is indirectly proportional. All right. Now, blood film. We're gonna talk about it again. I'm gonna repeat the same thing. It is it is considered as, yeah, macrocytic hyperchromic anemia. What would you consider something as macrocytic? As microcytic, it is less than 80 femtoliters. Okay, less than 80 femtoliters. All right. What is normocytic? 80 to 100. Okay, so 80 to 100, that's your um, normocytic. Macrocytic, just greater than 100. All right, you guys get it? We can move on. You guys understand the difference between transferrin and ferritin? Okay, from the name itself, transferrin is the transfer or the mobile form of iron. It is in the ferrous state, ferric state, sorry. All right, so we answered this question already. What is the storage form of iron? We're going to move on. That is ferritin. Clinical laboratory, how is transferrin activity measured? Oh, binaliktad. I just paraphrased the question, and it's in the form of total iron binding capacity. So why is this important? Because the disease that we're talking about is iron deficiency anemia. All right. All right. Okay. So it's a nice to know question. Um, Rarely asked in the board exam, and I haven't encountered it in my exams in the hospital or in college. But this is a triad of clinical findings that is closely related to IDA. If you're going to take medicine, this is a question that they're going to ask you. But for medical technologists, it's not really common, and that is known as Plummer-Vinson syndrome. Okay, so what is Plummer-Vinson syndrome? There's a triad. Imagine the plunger. When you draw a plunger, this is a mnemonic that they teach some of the students. Yeah, wait. Okay. So, imagine your plunger. Ano ba yung plunger natin? Yung pang-alis ng ano. The bottom part of your plunger is shaped like this, right? Okay. So the reason why it's shaped like that is because there's one, two, three parts of it. And that's the triad that you're going to look for. Okay, that's the reason why it's a triad, because there's, you can see esophageal webs, IDA, and dysphagia. What do you mean by dysphagia? There's loss of loss of appetite. Basically, you're not eating that well. All right. Okay. So that's your iron deficiency anemia. It's a microcytic anemia, and it is also related to iron binding capacity and iron storage form. Anybody has questions? Anybody? All right. We're gonna move on. We're gonna move on to sideroblastic anemia. Okay. So what is the etiology of sideroblastic anemia? So as I mentioned before, this is an abnormal production of the heme. But what particular part of the heme? You are going to talk about the porphyrin pathway, or the porphyrin pathway. So I'm not gonna, it's usually not asked in the board exam, the porphyrin pathway, because that's advanced biochemistry. If you're going to take medicine, you need to know that. But if for us as medical technologists, we're not gonna focus that much. Okay? So porphyrin pathway is basically how we produce porphyrin. Why is porphyrin important? Hang on. Somebody, all right. Sorry, somebody messaged me. All right. So why is porphyrin important? Because this is the part of the hemoglobin molecule that binds to iron. Okay? That's the reason why porphyrin is important. You can't have heme without porphyrin. All right? Okay? So that's the abnormality. So sideroblastic anemia is basically an abnormality in the heme group. So what enzyme is often inhibited in patients with sideroblastic anemia? So this is a genetic disorder, guys. So it's a genetic disorder, and you're going to have an abnormality with the ALA synthase enzyme. What is ALA? That is aminolevulinic acid enzyme. So there is an ALA synthase deficiency. So please don't forget ALA synthase. If you can't remember aminolevulinic acid, don't worry. You have another chance. ALA synthase. All right? So why? Why is it important? Because in the iron metabolism, in the heme metabolism, allosyntase actually is responsible for production of porphyrin 4. pH 4 na lang. Kasi my handwriting in the mouse is not good. All right? Why is it important? Because it will bind to globin, okay? To form hemoglobin, okay? And this particular portion will bind to iron. Okay, it's already bound to iron before binding to globin to form your hemoglobin. So without aminolevulinic acid, you will not have your porphyrin 4. That's why it's important. Acquired sideroblastic anemia is, I've mentioned it before. Okay, so please don't forget this. It is also another question that we call, well, that we refer to as a high yield question. So when I say a high yield question, this is one of the questions that is mostly tested in the board exam. And the causes of that one: acquired sideroblastic anemia. I think you've heard of this. Blank poisoning. Can anybody answer for me? What about who's the one that answered earlier? What about Friendiza? Hi, Friendiza. Are you here? Friendiza? Hey, girl. Are you there? Oh, silent. My gosh. Hello. Is anybody here with me? Everybody's a little bit quiet today. I don't know why. Hello. What about uh okay, sir, sira ang mic ko. All right. What about who else is here? Glyza La Chica. Hello, Glyza. Are you there? All right. All right. So, what are the acquired forms of anemia? You can give me. Ay, nagulat ako. Nagulat ako. May sumisigaw. Somebody answered. All right. Can you answer this question for me? Acquired sideroblastic anemia. All right, somebody raised her hand. What about Kyla? Kyla, are you there? Okay, do you know the answer for this particular question? Can you give me one reason why people experience acquired sideroblastic anemia? Okay, I'll give you a clue. I'll give you a clue. It's a drug used for tuberculosis. It's a drug used for tuberculosis. You can also have a chemical that is considered to be poisonous in the laboratory. No idea? It's okay. Don't worry. It's okay. What about another one? I need to find someone who can answer. Hindi ako maka-move on. Nobody will be able to answer. There. Somebody already answered. Sir Led po. All right. Thank you for answering. What about the other one? What is the drug that they use for tuberculosis that can cause sideroblastic anemia? Isoniazid. All right. Thank you so much. What are the drugs for isoniazid? We have RIP. Please don't forget RIP. RIP stands for rifampicin, isoniazid, and pyrazinamide. You can use also ethambutol. You can use the word ripe as your mnemonic. It doesn't matter, diba? I'm giving you guys ideas also for your bacteriology exams. All right. So hopefully you get to remember that mnemonic and remember me sometimes when you're answering your board exam questions. Okay. Next question. Why does isoniazid cause sideroblastic anemia? This is not usually a question asked in the board exam, but I'm going to humor most of you people because it's going to block your vitamin B6 activity. Why is vitamin B6 important? It is going to help produce your it is going to react with I'm sorry, it is a cofactor for your wait for it at the other end would be the allosyntase. Okay, it is a cofactor for allosyntase. So the reaction for allosyntase production is not going to happen if vitamin B6 is depleted or it's inhibited. So isoniazid actually blocks the activity of this one. So with that, you can see sideroblastosis. All right. What is the relevance? Okay, as I mentioned, we already answered that one. It blocks the import. It is going to block the allosyntase molecule or enzyme, and it's important because it cannot bind to heme molecules. All right. Of what effect does lead poisoning do to heme production? It's going to inhibit the action of ferrochelatase. What is ferrochelatase? It is going to be the one responsible for binding iron to the heme molecule. So ferrochelatase, from the name itself, iron, ferro. We're talking about iron. Ferrochelatase. Chela. We're going to go one by one. Chela means separating or adding. So, so great example of this is your EDTA. EDTA is a chelating agent for for calcium, sorry. So it separates calcium from the reaction. So ferrochelatase separates your iron from a specific reaction. In this particular context, it's going to separate the iron from from the plasma into the heme molecule. All right, so it's going to insert the heme molecule in your in the heme molecule. It's going to insert the heme in the heme molecule. Okay, so it allows the insertion of ferrous iron. Okay, in your protoporphyrin, specifically protoporphyrin 4. Okay, why is it important that we're talking about the ferrous iron and ferric iron? Why is it always important that we're talking about ferrous iron? Because sometimes in the board exam, they're going to ask you they're going to check whether or not you understand the difference between ferrous and ferric iron. So ferrous iron is Fe2 plus, ferric iron is Fe3 plus. Why is it important that the body in the why is it important that the ferric iron is in the ferrous state? Sorry, the iron molecules is in the ferrous state, because if it's in the ferric state, it can become a it can become a free radical, and it actually can destroy the cells of the body. So please remember that one. All right. That's the reason why we always have ferrous iron in our system. Actually, guys, in the human body, specifically in the cells, we're going to look at it in the dietary pathway, the nutritional pathway. So this is, for example, your stomach. Okay, it's going to be absorbed in the ileum. Iron is going to be absorbed in the ileum. Enterocytes are present in your small intestine. And there's going to be receptors there that will transform the ferric iron in our diet to ferrous iron. Okay? So that's the reason why it's important for us to have it, because the body will not be able to take in ferric iron. Aside from that, if it stays in the ferric iron inside our system, it will become an free radical. Sorry, it will become a free radical. All right. How is sideroblastic anemia detected in the laboratory? Well, we can use the same things. You can rely on peripheral blood smear. You can also rely on CBC. But the most important thing is that you're going to see ring sideroblast with Pearl's Prussian blue. Okay. Remember, Pearl's Prussian blue is a stain for iron, or it's a stain for iron. Okay. Okay. So guys, please don't forget, Pearl's Prussian blue is a stain for iron. So anything that you want to stain, whether it's a whether it's in histopathology, it's a bone marrow, or you want to demonstrate hemochromatosis in samples like liver biopsies, you can use Pearl's Prussian blue to demonstrate the ring sideroblastosis. All right. So it can be either in the blood film, it could be either in the bone marrow, or histological sections. Okay, so that's the use of your Pearl's Prussian blue. All right, clinical chemistry results that can differentiate patients from sideroblastic anemia to iron deficiency anemia. All right, so the problem with patients with sideroblastic anemia is that either there is poisoning or a person is deficient with allosynthetase. Now, there is no problem with iron deficiency. Therefore, what we're going to expect is the reverse reaction between iron deficiency anemia. In what sense? Increased ferritin, increased iron, decreased TIBC. See? See the difference? Decreased TIBC. So it's an opposite reaction with iron deficiency anemia. So please don't forget this one, because this is going to be asked in the board exam. Actually, it was asked in one of your if one of my sorry if one of in one of my exams. I can't remember whether it's in the ASCP or it's in the board exam, but this is a high yield question again, so I'm gonna put a star on it so you guys will remember it's important. All right, this one is the most important one. So they might present the question like this: patient, 72-year-old patient from the emergency room department, came in with signs and symptoms of anemia, blah, 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 fatigue, headache, pallor, those kinds of signs and symptoms. We're not gonna rely so much on physical findings. All right. Then they showed the labs. Labs indicate microcytic cells. Whether it's in the peripheral blood smear, the presentation of the patient is in the peripheral blood smear. You're going to see either the CBC result of the patient or a peripheral blood smear of the patient. So if you're going to look at the CBC, check out the MCB first. Why? We want to identify what type of anemia the patient has. So if it's less than 80, oh my gosh, this is macrocytic anemia. Oh, I know what to do now. I can select from one of the things that Sir Manuel told me. It's either sideroblastic anemia, iron deficiency anemia, thalassemia, or anemia of chronic disease. which we're going to discuss later. But just bear with me with the three ones. Okay. Now they're going to present another form of data, which could be in the form of which could be in the form of iron, ferritin, and TIBC, and that's how you're going to decide whether or not the patient is suffering from sideroblastosis or iron deficiency anemia. Okay, why is it when you hear the word blastic? What do you mean by why is it sideroblastic anemia? Why do I see sideroblasts? Well, basically, you're going to see ring sideroblast. And from our discussion last week, ring sideroblasts are considered to be your reticulocytes. Okay, specifically your polychromatophilic reticulocytes. And when you see polychromatophilic reticulocytes with peppered with peppered with deposits of iron, that's the time. Ah, the problem with the patient is probably with with too much iron in the system. Okay, so it becomes hemosiderin actually. Okay, this is what you call hemosiderin. All right. So please don't forget that. Don't forget the difference between the two. I marked it with a star. Okay, I wrote a lot of graffiti on it. So guys, you can remember that it's actually important. All right. So we're gonna move on with thalassemia. Actually, thalassemia is, according to my friend, it's one of the hardest anemias that you're going to encounter in the exam. Okay, but I'm gonna try to make it a little bit easier for you guys. So abnormality present in thalassemia is somewhat easy to understand. It's about globin chains. All right, it's about the abnormality in globin chain or hemoglobin chain production. So what are the hemoglobin chains? We mentioned it before last week. We have your normal hemoglobin, which will have your sorry, alpha and beta chains. For your fetal hemoglobins, what are the hemoglobins for your fetal for what are the globin chains for fetal hemoglobin? Can anybody answer? Anybody? Hemoglobin for fetuses. Okay, so we have this as HbA1. Okay, we have another one, A2. We have HbF. All right. So anybody knows the difference between what is our fetal hemoglobin composed of? What is our A2 and F? Anybody? An answer? I'm gonna call people. What about Ella? I haven't heard from Ella today. Hi, Ella. Ella, are you there? Ella Villamayor. Are you there? Yes. Hello. Hello, hello, hello. Yeah. What is the component of a hemoglobin F? Okay. But that wasn't my question. My question is, what are the components of hemoglobin A? Hemoglobin F. What are the components of hemoglobin F? Somebody raised their hand. What about Earl? Okay, Earl. All right, very good. What about hemoglobin A2? 2 alpha, sorry, 2 alpha, 2 gamma. Sino yung nagsalita na malalim ang boses? May nagsalita. Hi, April. This is my first time hearing from you. Hello, April. Alpha and delta. Alright, paano nga ba yung... How do I write the delta form? Triangle pala. Alright. So, Alpha, beta. I'm sorry, my handwriting is not good in the with the mouse, but hopefully bear with me, guys. A2 is 2 alpha, 2 gamma, and for your hemoglobin F, it's 2 alpha, 2 delta. Okay, 2 gamma. Sorry, 2 gamma. Okay, alpha delta, alpha gamma. So our shortcut here is ABDG. O, di ba, guys? So your AB, beta, gamma, beta, delta, and gamma. So you won't be able to, you won't forget. Okay? Because usually when you see electrophoresis forms or questions with electrophoresis, they will give you a data like this and you're going to fill it out. That's how it was asked on my friend's board exam. So please be mindful of this particular question. I'm going to put a star on it because I know it's going to be important and it's going to be a high yield question. All right? All right. So let's move on with the genes for coding. Alpha and beta genes are found in what chromosome? So a little bit of memorization. Hopefully you guys remember. Um, for your alpha chains, it's found in the 16th chromosome, and the beta chain is in the 11th chromosome. And alpha chains actually have 4 genes. All right, alpha chains have 4 genes for them. Beta chains have 2 genes. So what do I mean by 4 genes and four genes and 2 genes? Basically, there's 4 parts of chromosome. There's 4 codes in chromosome 16 that will produce alpha chains, and there's only 2 codes in chromosome 11 that will produce beta chains. So please be mindful of that one. All right. So the nomenclature of your thalassemia is based on the alpha gene that is being deleted. So I'll give you an example. Alpha thalassemia, the deletion is alpha chain. All right. So the deletion of the globin chain is actually the name of the thalassemia. So if I ask you if it's going to be what type of thalassemia, then you have to be able to understand that there is a deletion of what globin chain. For example, a question was asked like this: which of the following is the abnormality in a patient with beta thalassemia? Alpha chain, globin chain, alpha globin chain, beta globin chain, gamma globin chain, or the delta globin chain. So you might be able to answer that question a little bit easier now because there is there is your guide now, because the deletion of the globin chain is actually the name of your thalassemia. So it could be minor or major. Okay, and we're going to discuss this in the next topics. Okay, so what are the types of gene deletions in thalassemia? So you're going to have your 1, 2, 3, 4 gene deletions. All right. So it will present as either asymptomatic, mild symptoms, severe symptoms, and the last one would be hydrops fetalis. Okay. One gene deletion is considered as your beta alpha thalassemia minor. Okay. Why is it minor? Because you only have one gene deletion. It's not very, if the symptomology is not very, it's not there. Okay. The other three would be thalassemia major, alpha thalassemia major. Why? Because there is appearance of symptoms, mild anemia and symptoms. And minor is actually a carrier state. Okay? It's actually a carrier. So please don't forget these 4 types of deletions. Hydrops vitalis is actually a commonly asked question. Okay? What do you mean by hydrops vitalis? Hydrops vitalis is babies who are born with 4 gene deletions. So ganito kasi yung what do you call this? Allele. They call this an allele. How do I erase this one? Can I erase this eraser? So look at the top portion, okay? Where we're going to go and delete some of the things that I have here. So I'm going to illustrate for you guys what it looks like in the context of genetics. So this is what it looks like. You have alleles, and each person has two types of alleles. Ay, sorry, put on the highlighter. All right, so you have alleles. How is it presented in the context of genetics? It's like this. You have alpha, 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 and then one is deleted. All right, that's your one gene deletion. And you can say alpha, alpha, alpha blank, alpha blank. That is two gene deletions. There's going to be mild anemia. Now, three gene deletions you already understand. We're gonna go with Hydrops fetalis. There's literally no alpha genes. Therefore, the patient's hemoglobin has no hemoglobin A. Therefore, the patient has only a different variant of hemoglobin. All right. So abnormal hemoglobin patient present in patients with what abnormal hemoglobin is patients with three or more gene deletions of alpha thalassemia. This is what we call Bart's hemoglobin or HBH because there's a deletion of alpha chains. All right. Hemoglobin structure that is abnormal. So there's no alpha globin chains. All right. So no. Talagyan ko na there's no alpha globin chains. All right. So that's hemoglobin H. What is the composition of hemoglobin H? Basically, it's four beta chains. And we all know that if there's four beta chains, it's not a functional hemoglobin. Actually, it's a strong oxygen. It has strong oxygen affinity. But the problem is it cannot give off the oxygen. It cannot give back the oxygen to the babies. Therefore, they suffer from stillbirth because the moment they're born, the oxygen that they breathe in is not going into their tissues, and therefore it causes them to suffer from hypoxia. All right, so that's hydrops fetalis. The reason why hydrops fetalis occurs in, as I mentioned before already, high oxygen affinity but cannot transport oxygen to the tissues. Please remember that one. You have four globin chains, four beta globin chains, and the function is that it can bind to oxygen. However, it cannot transfer it to the tissues. That's the problem with Bart's hemoglobin or HbH. Okay? So what are the types of gene deletions in the following populations? For Asian and African, it's different. There are several types of deletions. We have your cis and your trans deletion. So it doesn't necessarily have cis and trans doesn't usually just apply for a person's sexuality, but it actually applies for a person in genetics as deletion on the same chromosome. So I'll give you an example of this. So again, we have two alleles, all right? Okay, this is allele 1 and allele 2. So a cis deletion is deletion on the same chromosome. So for example, you have alpha thalassemia major and the deletion is here. You still have alpha chains here, alpha genes here. Okay? Now, if you have a trans deletion, it would be something like this. And we're going to remove the other one. Okay? So that is your trans deletion. And it occurs in Asian for cis deletion, African for trans deletion. So mnemonic is that for all alpha thalassemias, you just need to remember A. It either occurs on Asians, it either occurs on Africans, and then you're going to say AC and AT. AC for cis deletion, because this I suppose this is a question that is usually asked. Okay, and African for trans deletion AT. All right. Guys, you guys understood what thalassemia is now? All right. Everybody clear? Can I hear a hell yeah, sir? Oh, may sumagot na isa. Yeah. I hope somebody said yeah. I just want to wake you guys up. Because I know it's really early, but hopefully we get a warm up as we move along. Okay? No questions? We can move on to. All right. Beta thalassemia is prevalent in Italians or Mediterranean population. All right. So if you're going to marry some, why is it common in the Mediterranean? Because in the Middle Ages, in order for um, people in the aristocratic level, this is historical. People from the Mediterranean usually marry their relatives in the Middle Ages and even sometimes in the Renaissance period. And this has caused a lot of problems with genetic. This has caused a lot of genetic problems with inbreeding. So people who actually breed with their relatives in incestuous relationships or what we call consanguineous relationships is actually going to produce heirs that have problems with their genetics, and that is the result. And the result of that is thalassemia. All right. So beta thalassemia. There are several types of thalassemia. We have thalassemia minor and thalassemia major, thalassemia intermedia. Okay. So we're going to go one by one. Mild and asymptomatic anemia for thalassemia minor, intermediate co-inheritance of alpha thalassemia trait. So what do you mean by co-inheritance? You have alpha thalassemia trait, and then you also have beta thalassemia. Now that's what we call thalassemia intermedia. Next one is major thalassemia is that both globin chains are blocked. All right, so for major thalassemia. Now, minor thalassemia, you only have two genes. So we're gonna move with genes. We're gonna go back again with genes. So I'm gonna go another and make another drawing. So remember, we have only have two genes for beta thalassemia. For alpha thalassemia, the reason why I have four underlines here for the alleles is basically because we have four. But in this case, we have only two genes. And if you have thalassemia minor, beta thalassemia minor, you're going to have only two genes. So what is the difference? Beta thalassemia minor, you have a deletion with only one. All right? Beta thalassemia minor. But for beta thalassemia major, you basically have nothing on your beta gene pool. So basically, you're producing a different gene altogether. And without beta genes, the body will produce gamma genes. Because what's the next one? Hemoglobin A, hemoglobin A2, hemoglobin F. Okay? So we have three types of hemoglobin. Because you don't have hemoglobin A, because you don't have A, alpha and beta, you're going to produce these two. Okay? What's the composition again? At our shortcut is B, D, G. So when a person's sample with thalassemia major undergoes electrophoresis, they won't produce HbA2. They will produce increased levels of A2 and hemoglobin F. Why? Because the remaining genes that they have will compensate for the absence of beta genes. So you're going to have A2 and F in the system. So this can range from either 30% to 80%. Is this still compatible with life? Of course, it's compatible with life, provided that the patient undergoes transfusion, which we're going to talk about later when we move on to transfusions. All right? Everybody understands the difference? Was I able to clear some of the misunderstood information about thalassemias? This is the easiest way for me for me to differentiate alpha, beta, major, minor, and intermediate for you guys. That's how hard it is for many people who are studying for their board exams. And again, I will say this is another important part of the exam because I'll remove this one because thalassemia is part of the question pools that they ask in board exams. It was actually asked in my friend's ASCP. If you're planning to take the ASCP exam, you have to be able to understand these types of questions or this particular form of knowledge. All right. Okay, so what test can be used as a differential diagnosis for beta thalassemia minor and beta thalassemia major? So we're going to use hemoglobin electrophoresis. As I mentioned before, that's the only way for to be able to differentiate between them. Why? Because for minor, there will be a decrease, just a decrease of HbA because you still have one gene that's producing hemoglobin A. Then you have a marked increase of either both of A2 and F, okay? But for intermediate, it's different. You're not producing any of the other ones, or you have a decreased production of HbA2 and HbA1, and the predominant hemoglobin in your blood cells is hemoglobin F. All right? So it's done by electrophoresis. So the differential diagnosis is done by hemoglobin electrophoresis. All right. Another term for basal thalassemia major, they might give you a question. That's the reason why I put other names in this in this PowerPoint slides, is because I want you guys to be familiar with the other names. Because sometimes the examiners are crazy and they might ask you questions in the form of Cooley's anemia, diba? Like that. They might ask you a question. That's the reason why they ask. That's the reason why I include this. Other name for thalassemia is Cooley's anemia, thalassemia major. All right, beta thalassemia major, Cooley's anemia. Please don't forget that one because sometimes you might have crazy examiners and they would say a patient is suffering from Cooley's anemia. Which of the following would most likely be true? Right? So sometimes they reverse the question, they paraphrase the question in such a way that, oh my gosh, I should have known the other name of that particular disease. So please be mindful of the other names as well. Okay? Now, let's move on to the blood cells that are predominant in the blood smear of patients with thalassemia. Obviously, this is going to be podocytes, or what we call target cells. Oh, why isn't it there? Let me check. Why isn't that thing there? It's not there. Oh, predominant cells. I'm supposed to write. Let's make. I'm just gonna make another one. Thalassemia. Okay. So you guys understand? Hopefully you guys have understood the topic because we're gonna move on with. I'm gonna go for a. We're gonna go for a short break. Uh, Usually around 5 minutes. Okay. Because we're going to discuss anemia of chronic disease later. But I'm gonna make another one for this. Okay. Control M. Mm, Predominant cells would be your target cells or known as codocytes. Okay. Codocytes. We're gonna go for a break for a while.